9 of the Psychcast by MD Edge, where we bring you interviews with leaders in the fields of psychiatry and psychology, masterclass lectures, and relevant inspiration straight to your ears, with new episodes dropping on Wednesdays. I'm the voice of MD Edge Podcasts, Nick Andrews. Coming up later, a masterclass lecture from Michelle Magid. Her topic today, botulinum toxin for depression. Before we get to This Week in Psychiatry, I wanted to mention something that we're doing at MD Edge Podcasts in an effort to improve this podcast and all of our shows. We have a simple listener survey available for any of you who want to leave feedback. The goal of this survey is to learn a little bit more about you, interviews, lectures, timing, production, and really anything that can improve the show for you, the listener. I know there's a ton of things to do in the day, but if you like the show or if you have any thoughts on how to improve, please take a moment and answer a few questions. You can find the link to the survey in the show notes. Okay, it's time for This Week in Psychiatry, where we bring you the latest in psychiatry news from MD Edge. This Week in Psychiatry, conduct disorder in girls is finally getting research attention that is long overdue. The physiological and emotion processing abnormalities that underpin conduct disorder in teen girls are essentially the same as in teen boys. However, the clinical presentation of conduct disorder in the two groups is often different. This is according to preliminary results from a European study called FEMNAT-CD, which is the first large study of conduct disorder in girls. The importance of FEMNAT-CD lies in the fact that nearly all previous research of conduct disorder has been conducted among boys. Therefore, there is no specific treatments available for girls. Dr. Bruce Jancin is a senior researcher and deputy head of the Department of Child and Adolescent Psychiatry at Amsterdam University Medical Center. Dr. Jancin reported the findings at the 2019 Annual Congress of the European College of Neuropsychopharmacology. That meeting was in Copenhagen. FEMNAT-CD is a multidisciplinary study aimed at exploring sex differences between boys and girls with and without CD in terms of brain structure and function, genetics, hormone levels, emotion recognition and regulation, and autonomic nervous system activity. The main finding was that there were no major differences in physiology between male and female conduct disorder. Dr. Jancin and colleagues focused on the autonomic activity and emotion processing portions of the study. In the study, researchers examined low prosocial emotions, or LPE, which is a term that is included in the DSM-5 used for individuals with conduct disorder who exhibit callous, unemotional traits. The researchers analyzed results for nearly 300 girls and nearly 190 boys with conduct disorder. They also compared results for cohorts of similar size and age-matched boys and age-matched girls. The researchers found that the LPE specifier was present among 37% of nearly 300 girls in the study and among 50% of 187 boys. Researchers found that girls with conduct disorder not only had a lower rate of LPE symptoms than boys, but 32% of girls also had anxiety and other internalizing comorbidities compared with 22% of boys. In an examination of how conduct disorder manifests, Dr. Jancin and colleagues demonstrated for the first time that both the callous, unemotional, and the threat-based reactive aggression forms of conduct disorder are present in girls as well as in boys. And that concludes This Week in Psychiatry. Remember, you can read this story in its entirety and more like it at mdedge.com/psychiatry. You can find a link to this story in the show notes. It's time now for our masterclass lecture. Please welcome Michelle Magid.
My name is Michelle Magid. I'm a psychiatrist. I'm an associate professor at the University of Texas in Austin. I'm also an associate professor at Texas A&M University. And today I'm going to be talking about botulinum toxin for depression. Some things I need to disclose is I am a speaker for Ipsen, who's the maker of Dysport, and I'm also a consultant for Allergan Pharmaceuticals, who are the makers of Botox. So let's talk about botulinum toxin for depression. Let's start off by talking about what botulinum toxin is. So botulinum toxin is the product of Clostridium botulinum. It's a bacteria that produces the neurotoxin botulinum toxin, which is often known as the most poisonous substance to mankind. So one would argue, why on earth would we be using this for medical purposes? So what we learned about botulinum toxin is that the neurotoxin inhibits the release of acetylcholine and results in flaccid paralysis of the affected muscles. And we have been using this now to our advantage. When people hear about botulinum toxin or Botox or Dysport, what they usually think about is reduction in wrinkles. But that's actually not where botulinum toxin got its medical start. Botulinum toxin actually started as an ophthalmology treatment. In 1989, it was used to treat strabismus, which is cross eyes, and blepharospasm, which is muscle dystonia in the eyes. We're also using it now to treat axillary hyperhidrosis, which is sweating in the armpit area, as well as chronic migraine. It got FDA approved for chronic migraine in 2010. And the cosmetic use of botulinum toxin only happened in the United States in 2012. So today we're going to be talking about botulinum toxin for depression. And as I say this, we have to keep in mind that this is off-label use, as this has not been FDA approved yet. So botulinum toxin for depression is very early in its research career. So far, there's only been 4 case series and 5 randomized control studies. So very recently, there's been a pooled analysis of 3 randomized controls trials in the use of botulinum toxin for depression. And what we did in this randomized control trial is we looked at 134 patients, all adults, 59 received botulinum toxin and 75 received placebo. The baseline Beck depression inventory for the botulinum toxin group was about 28, and the baseline Beck depression inventory scale for the placebo group was about 26. The women received 29 units into the forehead, and the men received about 39 or 40 units, depending on what study was investigated. The baseline variables for both the placebo and botulinum toxin group did not differ. These included the number of patients currently on antidepressants, which was about 64%, and the number of years patients had been struggling with depression, which was about 19 years. When you look at the results of this meta-analysis, what we discovered was the response rate in patients who received botulinum toxin was 54.24% at 6 weeks, compared to the placebo response rate, which was only 11% at 6 weeks. This was in both the MADRS and HAM-D rating scales. When you looked at the response rate in the self-rating scale, the Beck depression inventory, the results were very similar. There was a 52.54 response rate in the botulinum toxin group versus an 8% response rate in the placebo group. And with all the information from the pilot studies, Allergan, the makers of Botox, decided to do a drug company-sponsored, large U.S. multi-center proof-of-concept phase 2 randomized controlled trial. In this trial, there were 258 females who struggled with moderate to severe depression. In order to be included in the trial, the patients had to score above an 18 on Hamilton Depression Rating Scales. The patients were randomized into one of 3 groups. A quarter of them were receiving 30 units of botulinum toxin into the forehead. A quarter of them were receiving 50 units of botulinum toxin into the forehead, and half of them were receiving placebo. The results of this trial were somewhat mixed. The endpoint of this trial was the reduction in MADRS score at week 6, and the response rate in MADRS score at week 6. And what we discovered was with the 30-unit dose, there was a negative 4.2 drop in MADRS score at week 3, which was statistically significant, and there was a negative 3.6 drop in MADRS score at week 9, which was also statistically significant. However, the reduction in MADRS score at week 6, which was negative 3.7, was not statistically significant. In order to be statistically significant, the p-value has to be less than 0.5, and unfortunately, at week 6, the p-value was 0.53, just missing statistical significance. What we discovered in the group that received 50 units of botulinum toxin is that there really was no real divide between the placebo and the active control group. So what do we do with all this information? Well, the first thing we have to wonder about is why the group that received less botulinum toxin actually did better than the group that received more botulinum toxin. The other thing that is worthwhile to take home is how incredibly safe and well tolerated this active The second thing to take home is how incredibly safe and well tolerated this treatment was. With the information from phase 2 trials, Allergan has indeed decided to move on to phase 3 trials, and we're looking forward to those results. So a big question that I get is this all just about looking better? Do people feel better because cosmetically they look better, and so that leads to less depression? It's an excellent question, and of course more studies are needed. But the answer to this question thus far is no. So we did a sub-analysis from our pooled analysis in order to answer this question, and we investigated if there was a link between improvement in appearance, as defined by a decrease in the number of wrinkles, and the improvement in mood, as defined by a decrease in the amount of depression symptoms based on the objective measurement scales. We first looked to see if people with more wrinkles before their treatment got more benefit to their depression, and the answer was no. The second thing that we looked at was to see if patients who had a bigger improvement in their wrinkle scores would also have a bigger improvement in their depression scores, and again the answer was no. So thus far, the study revealed that there is no link between improvement in appearance and improvement in mood. Another question that I get is, how much does this treatment cost? Well, the answer to that question really depends on the person who's giving the treatment. But a 50-unit bottle of botulinum toxin costs about $320. So when you do the math, 30 units of botulinum toxin costs about $185. If you're giving somebody 30 units of botulinum toxin, the product costs $185, and you're going to charge a procedure fee as well. That turns out to be about $400 per treatment. Now, some might say this is a lot. However, when you think about it and do the math, the treatments will be given about 3 to 4 times a year. So that ends up being about $1,200 to $1,600 per year for the botulinum toxin treatment. Compared to psychotherapy or brand medications, the cost really isn't that much if the treatment is beneficial. Finally, one question that I get asked a lot is, if this is FDA approved, who will actually administer the treatment? And that's something that I've been wondering myself as well. It does appear that the best people to administer the treatment would be psychiatrists. However, that will require us to touch our patients. So I can imagine if you're doing psychoanalytic work, this would not be your cup of tea. However, nowadays, with esketamine treatments, with transcranial magnetic stimulation, and with the oldie but goodie electroconvulsive therapy, I do believe that psychiatrists are becoming more and more comfortable with procedures. As such, I do think it will be a treatment that is in our domain. I can also imagine specific dermatologists and family practitioners taking hold of it as well. I think the time is right for botulinum toxin. I think we are entering a new phase of psychiatry. We all grew up learning about the monoamine hypothesis. And what that basically means is there's a defect in serotonin and norepinephrine and dopamine, which causes depression. But with current research, and especially with this conference that we attended today, we're learning that depression is just much more complicated than that. We're learning that depression can be an inflammatory disorder. We're learning that depression may be due to hormonal imbalance. We're learning that depression, some people believe, is a pain disorder. So it does make sense that something that can treat migraines, which is a pain disorder, might be able to treat a subset of people with depression. That's another theory of behind the mechanism of action, that maybe depression is a pain disorder and botulinum toxin is working on a mechanism to reduce pain. I also think that because a third of our patients are treatment resistant, that's about 33% obviously, we have a lot of room for growth in psychiatry. And we need to start thinking about novel treatments. We heard today about ketamine treatment. We heard about brexanolone for postpartum depression. We're hearing about hormone replacement. We're hearing about anti-inflammatories. I do think the time for a novel tool in our toolbox is here, and botulinum toxin might be that tool. Another question that people ask me is botulinum toxin safe? As I said earlier, botulinum toxin is known as one of the deadliest compounds to man. So why on earth are we injecting this into our body? And the answer is, with the altercations that we've done, botulinum toxin is incredibly safe. In fact, in our meta-analysis, 13.6% of the botulinum toxin group versus 9.3% of the placebo group experienced some adverse event. And the adverse event was very mild, and these included temporary headaches and local irritation immediately after the injection. The other thing is botulinum toxin has been used for over 25 years for other medical causes, and thus far, you can look at the safety record, it is incredibly safe. Another question I get asked a lot is, does it work better in men or in women? And the answer to that is, we're not quite sure yet. When you look at the data, there's been a lot more women in the trials than men, so further studies are needed. Thus far, though, men are getting a good result. And finally, I get asked, is this better as a monotherapy or an augmentation strategy? Meaning, does this work better alone, or does it work better in addition to antidepressants? When we looked at a sub-analysis of the meta-analysis, we did not see any statistically significant differences between it being a monotherapy versus an augmentation strategy. However, when you look at the number, it does seem, it's not statistically significant, but it does seem that thus far, it does work a little bit better as an augmentation strategy. However, because the numbers are so small, further studies are warranted in that area as well. So in conclusion, there is increasing evidence that patients suffering from negative emotional states such as depression and maybe even social anxiety disorder and borderline personality disorder may benefit from injections of botulinum toxin A into the glabellar, also known as the forehead. However, larger studies are warranted. When you look at all of the data from the case series and the randomized controlled trials, we only have 528 patients so far. If future studies, however, emulate the current findings, botulinum toxin may be a novel treatment in the fight against depression and other psychiatric disorders.
And that's a wrap on episode 89 of the Psychcast by MD Edge. If you enjoyed that lecture and want to learn more, there are robust show notes available courtesy of Dr. Jacqueline Posada. You can find them wherever notes are found in your app. They include links and an outline of topics discussed. You can also find a link to our Psychcast survey and a link to This Week in Psychiatry. Okay, let's get to this week's credits. The Psychcast is hosted by MD Edge Psychiatry Editor-in-Chief, Dr. Lorenzo Norris. Our masterclass lecturer this week was Michelle Magid. Psychcast audio producers are Gina Henderson and Jeff Bauer. MD Edge podcasts are produced by executive editors Denise Fulton and Kathy Scarbeck, multimedia editor Terry Rudd, and our social media is produced by Kyla Clark. Show notes are authored by Dr. Jacqueline Posada. I am your audio engineer, audio editor, and the voice of MD Edge podcasts, Nick Andrews. You've been listening to the Psychcast by MD Edge.